Endometriosis is a chronic and often debilitating inflammatory condition that affects an estimated 1 in 10 women during their reproductive years, making it as common as conditions like diabetes in women. It is a condition where tissue that is similar to the lining inside your uterus, called the endometrium, grows outside of your uterus where it does not belong. This misplaced tissue, known as an implant or lesion, acts as endometrial tissue. It responds to the monthly hormonal cycle by thickening, breaking down, and bleeding. But because this tissue is outside the uterus, the blood and inflammatory byproducts have no way to exit the body. This process of internal bleeding leads to significant inflammation, severe pain, and the formation of scar tissue, known as adhesions. Receiving a diagnosis of endometriosis can be a long and challenging journey, but it is a crucial step toward management, validation, and reclaiming your quality of life. Understanding this complex whole-body disease is your first and most powerful tool. Types and stages of endometriosis. Endometriosis is classified based on its location, depth, and the amount of tissue present. The most common locations for these growths are on the ovaries, fallopian tubes, and the outer surface of the uterus, as well as the ligaments that support the uterus. It can also be found on the bladder, bowel, and in rarer cases, on the diaphragm or even in the lungs. The condition is often staged using a point system during surgery to describe its severity. It is critically important to understand that the stage does not always correlate with the level of pain a woman experiences. A woman with stage Y endometriosis could have disabling pain, while a woman with stage 4 might have fewer symptoms. Stage 1, minimal. There are a few small, superficial implants and no significant adhesions. Stage 2, mild. There are more implants and they are beginning to invade deeper into the tissue. Stage 3, moderate. There are many deep implants. There may be endometriomas, which are endometriosis cysts on the ovaries, and some flimsy adhesions are present. Stage 4, severe. This stage involves widespread deep implants, large endometriomas on one or both ovaries, and extensive, dense adhesions that can fuse organs together. This can lead to a condition called a frozen pelvis, where the pelvic organs are essentially stuck together by scar tissue, severely distorting the normal anatomy. There are also different types of endometriosis lesions, which require different management approaches. Superficial peritoneal endometriosis. This is the most common form, where implants are found on the peritoneum, the thin membrane lining the abdomen and pelvis. Ovarian endometriomas. These are cysts filled with dark, old blood that form on the ovaries. They are often called chocolate cysts due to their appearance. Deeply infiltrating endometriosis, or DI. This is a more severe form, where the endometrial tissue invades the walls of the pelvic organs, such as the bowel, bladder, or uterosacral ligaments, by more than 5 millimeters. Managing DI often requires a highly skilled surgeon and sometimes a multidisciplinary team that may include a colorectal surgeon or a urologist. The complex causes of endometriosis. The exact cause of endometriosis is still not fully understood, but it is considered a multifactorial disease. It is likely a combination of genetic, immunological, and hormonal factors. Several leading theories attempt to explain its origin. Retrograde menstruation. This is the most widely accepted theory. It suggests that during menstruation, some menstrual blood containing endometrial cells flows backward through the fallopian tubes and into the pelvic cavity instead of exiting the body. While most women experience some degree of retrograde menstruation, it is thought that women who develop endometriosis have an immune system dysfunction that prevents their bodies from recognizing and clearing these displaced cells. Their peritoneal fluid often shows different levels of immune cells and inflammatory markers compared to women without the disease. Cellular metaplasia. This theory proposes that cells lining the peritoneum, which originate from the same embryonic tissue as the endometrium, can spontaneously transform into endometrial-like cells under the influence of certain triggers, such as hormonal shifts or inflammation. Genetics. Endometriosis is known to run in families. If your mother, sister, or daughter has endometriosis, your risk of developing it is about 7 times higher than that of the general population. Researchers are working to identify the specific genes involved. Immune system dysfunction. A healthy immune system should recognize and destroy abnormal tissue growth outside the uterus. In women with endometriosis, there appears to be a failure of this surveillance system. There is evidence of altered T-cell function and reduced activity of natural killer cells, which are the immune cells responsible for clearing abnormal cells. Lymphatic or vascular spread. This theory helps explain how endometriosis can be found in distant locations. It suggests that endometrial cells can travel through the body's lymphatic system or blood vessels, similar to how cancer cells can metastasize and implant in remote areas like the lungs, brain, or skin. The clinical journey of this condition. The clinical course can be highly variable. For some women, it may be a mild condition that causes minimal disruption. For others, it is a progressive disease that can worsen over time, causing debilitating pain and significantly impacting fertility. The inflammation caused by the bleeding implants creates a hostile and toxic environment in the pelvis. The body's attempt to heal this chronic inflammation leads to the formation of scar tissue or adhesion. These adhesions are like internal strands of glue that can bind organs together, causing pain with movement and distorting the normal, mobile anatomy of the pelvis. This distortion can block the fallopian tubes or encase the ovaries, interfering with the release of an egg. This physical blockage is one way the disease affects fertility. Furthermore, the inflammation itself can negatively impact egg quality, sperm function, and embryo implantation. The condition is estrogen dependent, meaning the growths are stimulated by estrogen. Therefore, symptoms often improve during pregnancy and typically resolve completely after menopause when estrogen levels plummet. Recognizing the wide range of symptoms. It is a profound injustice that many women are told for years that their severe period pain is normal or in their head. If your pain interferes with your ability to go to school, work, or engage in daily activities, it is not normal, and it warrants a thorough medical investigation. Dysmenorrhea or painful periods. This is not just typical menstrual cramping. The pain associated with endometriosis is often described as a severe, deep, tearing, or burning pain that can radiate to the lower back and down the legs. It often starts days before the period and can last throughout it. Chronic pelvic pain. Many women experience persistent, non-cyclical pain in their lower back and pelvis. Dyspareunia or painful intercourse. Pain during or after sexual intercourse is a very common symptom, particularly with deep penetration, as it can put pressure on tender implants or stretch adhesion. Pain with bowel movements or urination, known as dysphagia and dysuria respectively. This pain is often worse during menstruation and can indicate that endometrial implants are affecting the bowel or bladder. It can feel like sharp, stabbing pain. Heavy menstrual bleeding. Some women experience excessive bleeding during their periods or bleeding between periods. Infertility. For about 30 to 40% of women with endometriosis, difficulty getting pregnant is the first and sometimes only sign that they have the disease. Other symptoms: chronic fatigue that is not relieved by rest, severe bloating often referred to as endobelly, diarrhea, constipation, and nausea, especially during menstrual periods, can also be associated with the condition. Getting professional help. Diagnosis and the gold standard. Diagnosing endometriosis can be notoriously difficult and often takes an average of 7 to 10 years from the onset of symptoms. This diagnostic delay is due to a lack of awareness and the normalization of women's pain. If you suspect you have endometriosis, it is crucial to find a gynecologist who specializes in the condition and takes your symptoms seriously. The diagnostic process involves several steps. Medical history. Your doctor will take a detailed history of your symptoms, their timing, severity, and their impact on your life. 2. Pelvic exam. During a pelvic exam, your doctor may be able to feel nodules or tenderness, particularly behind the cervix, which can be suggestive of endometriosis. Imaging studies. Ultrasound. A transvaginal ultrasound is effective at identifying ovarian endometriomas, but cannot visualize the more common superficial implants or adhesion. MRI. A magnetic resonance imaging scan may be used in complex cases to get a more detailed picture and to help plan for surgery, especially if deeply infiltrating endometriosis is suspected. Laparoscopy. The only way to definitively diagnose endometriosis is through a surgical procedure called a laparoscopy. This is a minimally invasive surgery where a surgeon makes a small incision in the abdomen and inserts a thin, lighted tube with a camera called a laparoscopy. This allows the surgeon to directly visualize the pelvic organs, identify endometrial implants and adhesions, and take a small tissue sample or biopsy for pathological confirmation. While this is the gold standard, it is a major surgery, and many specialists will make a strong clinical diagnosis to start treatment sooner, reserving surgery for when medical management fails or is not desired. There is no cure for endometriosis, so treatment focuses on managing symptoms, primarily pain, reducing inflammation, and addressing fertility issues. The treatment plan is highly individualized based on your symptoms, goals, and the severity of the disease. Pain medication. Non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen, can help with mild pain by reducing inflammation. Hormonal therapy. Since endometriosis is fueled by estrogen, hormonal treatments aim to suppress the menstrual cycle, prevent new lesion growth, and reduce inflammation. Hormonal contraceptives, birth control pills, patches, and rings can help by making periods lighter and less painful. Progestin-only therapies. These can be given as a pill, an injection, or through a hormonal IUD like the Mirena. They can stop periods altogether, which can provide significant relief from symptoms. GnRH agonists. These powerful drugs induce a temporary, reversible menopause by shutting down ovarian estrogen production. They are very effective for pain but are typically used for short periods, often with add-back therapy, which is a low dose of hormones to manage menopausal side effects like hot flashes and bone density loss. Surgery. Surgical intervention aims to remove as much of the endometrial implants and scar tissue as possible. Laparoscopic excision surgery. This is considered the gold standard of surgical treatment. A skilled surgeon meticulously cuts out or excises the endometriosis lesions from the tissue. This is far more effective than ablation, a more common technique where the lesions are burned off with heat. Ablation often leaves the root of the disease behind, leading to a high rate of recurrence. Excision surgery, when done thoroughly, can provide long-lasting pain relief and improve fertility. Hysterectomy. The removal of the uterus can resolve symptoms like heavy bleeding and uterine pain, but it is not a cure for endometriosis. If endometriosis implants are left on other organs, they can still cause pain. A hysterectomy is a major irreversible surgery that ends a woman's fertility and is typically considered a last resort for debilitating symptoms that have not responded to other treatment. Rehabilitation and living well with the condition. Rehabilitation after endometriosis surgery, particularly excision surgery, involves a recovery period of several weeks. A crucial and often overlooked part of recovery is pelvic floor physical therapy. Years of chronic pelvic pain cause the pelvic floor muscles to become chronically tight and spastic, creating their own layer of pain. A specialized physical therapist can help release these muscles and break the pain cycle. Living well with endometriosis is a long-term journey that often requires a multidisciplinary, holistic approach. This can include dietary changes. Many women find that an anti-inflammatory diet, which limits processed foods, gluten, dairy, and sugar, can help manage symptoms by reducing systemic inflammation. Alternative therapies, acupuncture, chiropractic care, and massage can be beneficial for managing chronic pain. Mental health support. Living with a chronic, invisible illness is incredibly challenging and can lead to anxiety and depression. Seeking support from a therapist or joining an endometriosis support group can be invaluable for coping and feeling less isolated. Research and expert perspectives. Scientists are working to develop non-invasive diagnostic tools, such as blood tests or new imaging techniques, to eliminate the multi-year diagnostic delay. There is also extensive research into the genetic and immunological causes of the disease, which could lead to more targeted and effective non-hormonal treatments. Leading specialists in the field are fierce advocates for early diagnosis and better care. Tamer Sekin, an endometriosis surgeon and co-founder of the Endometriosis Foundation of America, is a prominent voice. He emphasizes the importance of skilled surgery, stating in his work, "Excision surgery is the gold standard of treatment that can effectively remove the lesion. It is of the utmost importance that it is done by an experienced surgeon." This highlights the difference between general gynecology and true specialization. The World Endometriosis Society provides guidelines and promotes research globally. Their consensus statements highlight the debilitating nature of the disease and the urgent need for greater awareness. They emphasize that endometriosis-associated pain has a severe impact on the quality of life, work productivity, and social relationships of affected women. The collective message from the expert community is one of validation and hope. Your pain is real. Endometriosis is a complex, whole-body disease, not just a gynecological issue. While the path to diagnosis and management can be difficult, advancements in surgical techniques, a better understanding of the disease, and a growing global community of advocates are changing the landscape. With the right medical team and a comprehensive management plan, it is possible to manage endometriosis and live a full and active life.